I was asked to speak to the group about transfusion-associated circulatory overload. I have nothing to declare. You already heard a little background about me. Just to let you know, I'm working at a hospital, a large community hospital that has just over 800 budgeted beds, although I would say that we're steadily working at overcapacity of about 150%. And we do about 4,500 red blood cell transfusions in a year at 5 different sites. The learning objectives were shared ahead of time. So here's my first polling question. Which transfused volume is most likely to cause a taco reaction? 300 mils, equivalent to 1 RBC, more than 300 mils, 50 mils or less than 1 unit RBC, or any volume can cause a taco reaction. Okay, great. Question 2. What type of blood product can cause a taco? RBC only, RBC, plasma, or platelets, IVIG, fibrinogen, albumin, or any blood product? Great. Okay. And the last question, what causes a taco reaction? Patient-specific factors, the volume of the transfusion, product-specific factors, or a combination of all of these? Okay. So the idea of the pre-questions is to kind of get you thinking along the pathway of what I'm going to talk to you about. This is just a little general overview. Talk about patho, criteria, risk factors, incidents, and then I'm going to try to fit 2 cases into my timeline. Just better make sure, keep an eye on the time. So we're talking about taco, which generally we can define as pulmonary edema caused by fluid overload. But there are 2 other transfusion reactions that present as respiratory distress that we also need to keep in mind. That's the TRALI, or the transfusion-related acute lung injury, which is also pulmonary edema, but seems to be caused by more immune factors related to factors within the transfused product. And then we also have TAD, which is a transfusion-associated dyspnea, which you should really consider like a rule-out kind of catch-all, as in we're not quite sure it fits perfectly into one of the other 2 options, so it has to be this. Think of it as like a combination of all of the factors, or even not enough information. So just jumping back to taco, so the patho, the full mechanism of action is yet unknown. We thought we had it. We originally hypothesized that this was a straightforward increased pulmonary pressure leading to pulmonary edema. But as researchers continue to work in this area, we see that there may be an inflammatory component, may be related to storage lesions. And the bottom line really is there any value in pulling apart these 3 different respiratory type reactions, or should we really be grouping them together just as sort of our dyspnea type reactions? So something to consider as we work through this. There's a lot of criteria out there, and depending on who you talk to, they may use different criteria for saying, yes, this is definitely a taco or definitely not. The American Association of Blood Banks gave us a 2018 definition, which requires that at least 3 of these are met. The 6 items being respiratory compromise, within 12 hours of transfusion, evidence of pulmonary edema, with cardiovascular changes, with evidence of fluid overload, And if the BNP or the NT-proBNP is elevated, and you may or may not know that's the chemical marker of cardiac stretch. TTISS, which is the reporting agency for Ontario, gave us a sort of older 2007 definition that kind of meets up with our newest AABB, but kind of not. The time frame is slightly shorter and it includes some other elements. And then one final thing to consider is a new sort of guiding chart, let's call it, was brought out in 2020. This hopefully is familiar looking to most of you. And this is not so much to identify if it was TACO or not, but really to guide clinicians on what they should do if they see symptoms that are kind of TACO-ish. So this is the first page, and then the second page really has what we're talking about, the dyspnea section. And just kind of, you know, the suggested treatments and the recommended investigations are really like the key purpose of this table. So risk factors for TACO, as we have defined them, are cardiac dysfunction, renal dysfunction, positive fluid balance, a previous TACO, and an older age of greater than 60. I think of the first four as like the fluid factors, as in fluid is difficult to move around with cardiac dysfunction, fluid's difficult to excrete with renal dysfunction, we already have too much fluid on board with someone who is positive fluid balance, or there is a history of problems. We know they have a history of problems with fluid management in people who have had a previous TACO. But then we can also add to those sort of risk factors. Pediatric and neonatal patients are also more at risk of having a TACO based on their the amount of blood volume in the smaller volume in the smaller bodies is not always as consistent as it is in an adult. And then SHOT UK 2021, that's serious hazards of transfusion. They do a lot of work around transfusion management in the UK, and they came out with some additional risk factors, suggesting weight-based dosing for all populations, because the assumption is if someone is sort of a smaller adult, it's easier to overtransfuse them. And then they also suggest that transfusing non-bleeding patients doesn't actually treat the cause of anemia, and they're more likely to overtransfuse in that case as well. So if you kind of pull those into the risk factors as well, you might consider weight and symptomatic anemia, as in someone who's underweight is more likely to have risk of TACO, and someone who has symptomatic anemia as a reason for being transfused is also more likely to be at risk for TACO. Bloody Easy 4 in 2020 showed us the incidence of TACO as sort of a 1 in 100 transfusions. And the SHOT UK, just to compare, their 2021 numbers are about 130. We will get back to that, but I just wanted to point out sort of the last 3 bars there in the context of like COVID, that we have seen like a little bit of an uptake on TACOs being reported in that area. At the same time, we're transfusing less, or at least we are in Ontario. I'm not sure if that's consistent with the UK findings. So let's jump into a case with all of those sort of setting you up to understand what's happening in a TACO. So the first case is an RBC, 83-year-old female with moderate to severe Alzheimer's dementia, non-insulin dependent diabetic, lives in a nursing home, had ongoing GI bleeding for 6 months, with out of hospital hemoglobin measured at 66 a few days before presenting to ED. The family refused a scope on the patient's behalf as she would not tolerate the PrEP, nor would she tolerate treatment if there were a diagnosis. The order was for 1 unit of RBC and a Venofer infusion for her anemia, and the Venofer was administered, completed 1 hour prior to transfusion. So prior to transfusion, her vitals, she was afebrile, heart rate was sort of high normal, blood pressure 142 on 58, respirate 20, and 92% on room air. At the start, an appropriate slow rate of 50. After 52 minutes, about an hour, the blood pressure had increased to 160 on 97, which is a jump of 20. Respirate was about the same at 22. The transfusion was stopped and 50 mils of the unit had been transfused because they did not increase the rate. Another hour after that, or 2 hours after start time, patient experienced sudden dyspnea and required a BiPAP from room air at 45% with a respirate of 29. And the MD noted on assessment they had diffuse crackles. Now, this documentation did not include accurate ins and outs. They had recorded negative liter, but when the chart was reviewed, there was clearly some pieces missing to the in and out tabulation. So the treatment was 40 milligrams of IV Lasix, and after that, the patient dumped 1,400 mils. Chest x-ray showed diffuse bilateral interstitial markings, suspicious for edema, and negative post-cultures. And T-proBNP was elevated, and her troponins were also elevated. So at 22:22, the patient's oxygen requirements began to steadily increase. After Optiflow was applied, the family decided not to escalate care any farther, and the patient expired approximately 27 hours post-transfusion. So with all of the information that I've shared so far, do you think this is a TACO or not a TACO? There should be a poll that you can. Okay, great. It looks like we had like an overwhelming yes, this is a TACO. So let's just go through, this is actually how I assess my cases when I'm going through a case of suspected transfusion reaction. I just kind of make myself a little checklist. So did this patient have respiratory compromise? Yes, definitely. Was this within 12 hours of transfusion? Absolutely. Was there evidence of pulmonary edema? We saw that on the chest x-ray. Were there cardiovascular changes? Yes. Blood pressure jumped up 20, although generally our threshold is actually jumping up 40. There were changes. Was there evidence of fluid overload? Both because she was responsive to the Lasix and the new presentation of the diffuse crackles, also keeping in mind that the documentation perhaps was not accurate in this case. And was BNP elevated? Yes, definitely. Now, we did indeed meet those three indicators, so we definitely would call this a TACO, but here's some confounding details that we should also consider. There was a veno for co-infusion. So are we actually looking at an adverse drug response, or as in not a response to the transfusion, but rather to the vinifer? There was an elevated troponin. So was the death actually caused because this patient was having an active MI rather than a TACO? And of course, the missing and inaccurate documentation also complicate assessment. So we summarize that this was a possible transfusion imputable incident, possibly related to cardiorespiratory insults, that both possibly played a role in the death. And we reported to CBS as per the guidelines and to suggest donor flagging for future donations from this person. CBS returned the response as this was a probable death relating to the TACO. So if you just jump back and look at the risk factors for this patient again, you'll see that the ones that are not italicized are sort of our standard assessments. And we didn't actually know about the cardiac dysfunction until after the transfusion really started going and we had assessed the troponins. We didn't know she had elevated troponins ahead of time. So really the only risk factor that would have flagged for us was her older age. If we add in those extra risk factors that the SHOT UK suggested, then definitely she had symptomatic anemia and a long-standing recent history of it. So we may have flagged her and treated her perhaps a little bit more cautiously if we had taken those into account. Okay, second case, albumin. So just a reminder, albumin is 25% albumin is a human plasma derived product, which increases blood volume by 3 to 4 times. As in, when you infuse 100 mils of albumin, it should become 300 to 400 mils in vivo. This happens by drawing fluid into the blood from the interstitial space, which is why we often use it as a volume extender post-paracentesis in hemodialysis, and we often see it in like a third spacing situation for other reasons. So the case itself is a 63-year-old gentleman who has ETOH use disorder with cirrhosis and portal hypotension with esophageal varices, small volume ascites, and significant peripheral edema. He had a recent admission and discharge for gallstones, also has bilateral leg cellulitis and an AKI. This patient had a fall at home with presumed sepsis stemming from his cellulitis in his legs and developed hypotension requiring an ICU admission. His in-outs are positive, 1.6 liters, and he has +3 pitting edema on his legs. The order was placed for 100 mils of 25% albumin for his hypotension and third spacing. So I just kind of pushed all that up here. Actual transfusion details started at 21:45. Approximately 1 hour into the transfusion, patient developed hypoxia, 97% on room air, down to 86%, with a total volume infused of 75 mils, or 75% of the infusion. Respirate jumped up 7 from 17 to 24. Other vital signs remained unchanged, and the patient was restless. So the treatment for this patient was Lasix, and also an introduction of oxygenation via nasal prongs at 4 liters a minute. Diagnostics, chest x-ray showed suspicious for CHF or pulmonary edema with no evidence of hemolysis, negative post-cultures, and an elevated NT-proBNP. So was this a case of TACO? Yes or no? Sheena, can you put that poll up? Okay, so it looks like majority voted yes for TACO, 20%-ish voted no, and then we had a couple that were undecided. So let's go through the checklist. Like I said, this is the best way to do it. So was there respiratory compromise? Yes, definitely. We saw that big drop in the oxygen saturation and the respiratory rate increase. Did this occur within 12 hours of the transfusion? Absolutely. Just within an hour, we saw that change. Was there evidence of pulmonary edema? Chest x-ray did show the pulmonary edema. Were there cardiovascular changes? We did not see any changes. Remember, they remained unchanged from the baseline. Was there evidence of fluid overload? The patient did have a positive fluid balance and also the 3+ pitting edema, so definitely there. And was the BNP elevated? It was. So in this particular case, we definitely met our minimum 3 indicators. We had 5 out of 6. And I often find that Lasix responsiveness is a deciding factor, mostly when you're trying to determine between different kinds of respiratory type transfusion reactions. If they are Lasix responsive, then we assume that it's a TACO component. So this sort of capitalized summary is actually what we published the patient chart, concluding TACO given the volume clearance impairments and the volume associated hypoxia, dyspnea, and wheezing with radiographic changes and the observed management approach, although we cannot rule out emergent features of underlying respiratory pathologies. So if you just want to jump back to the risk factors, the patient did have 3 of the risk factors that we commonly screen for renal dysfunction, the AKI. He had a positive fluid balance and he was over 60. So this is definitely a patient that we should have been more cautious with and expecting a TACO reaction. One of the physicians I work with, Dr. Churdy, was kind enough to share this paper that they had presented previously to CSTM in 2017 about TACO, and she sort of in discussion shared these comments with me that some of our worst cases of TACO have happened with albumin. They audited 241 cases for this paper, cases of TACO, and they had 2 with only albumin bottle exposures, as in no other sort of possible culprits. And those exposures were of 2 or more bottles that led to a TACO reaction. And since this poster, she's seen several more cases. So I really wanted to introduce the albumin case to just highlight that albumin can cause TACO, that we are seeing evidence of it, that the case I presented to you is like sort of a definite TACO case, just like the RBC case, and that it is not a common finding, but it is something that we can see. So for all transfusions, we are expected to sort of identify those risk factors and take appropriate action. So one of the ways that we encourage people to do that, particularly at my corporation, is we've actually added the TACO risk factors into the RBC transfusion instructions to remind the prescribers to keep these things in mind. But also the bedside transfusionist, as in the person who's actually administering the transfusion, needs to also keep the risk factors in mind. And the best thing you can do, even if the physician has ordered a fairly rapid transfusion, is choosing a transfusion rate that's appropriate to your patient, particularly if they have risk factors. So if you're seeing a patient like that gentleman that we discussed for albumin, choose a slower infusion rate. It doesn't have to go in over an hour or over 30 minutes. To compare the two cases, just to sort of put it on paper in front of you, the risk factors we kind of went through pretty well. The volume infused of the RBC was only 50 mils. The volume of albumin was only 75 mils. And I think that really highlights that even though this is like a circulatory overload concern, as in like based on fluid, it is not caused by a large amount of fluid. And to extend that even farther, in cases of like a massive hemorrhage protocol activation where we give multiple units to patient, I myself haven't investigated any reactions that are suspicious for TACO linked to these MHPs, as in the more units or the more volume doesn't necessarily mean that we're going to see a TACO reaction. And then the last thing that's interesting, I think, is the indicators that the patient that we didn't really identify as having risk did actually have all the met indicators for identifying a TACO reaction. And the patient that did have quite a few indicators similarly met lots of the AABB criteria. So I said I was going to circle back to these sort of how many kind of TACO reactions are we actually seeing slides. So there's the Bloody Easy from Ontario on the left and the UK on the right. So the 1 in 100 transfusions, I always ask myself, are we actually being more vigilant looking for these cases in some populations than others? We have a really robust outpatient cancer center, as well as we're the regional hemodialysis center. These patients get transfused more, so are we looking for these transfusion reactions in these patients more often? And then on the TACO side, as I said, they had about 131 TACO reactions in the UK in 2021. And their data shows that they're seeing TACO in about 1 in 23,000 transfusions. The denominator is based on the number of products issued. So their numbers are not matching up with what we're reporting. And then when I pull data just sort of from my corporation, which it's a very small data set, so you can't extrapolate our findings to anywhere else. But in 2021, we did 4,500 component transfusions, and we had 3 TACO in 49 reactions. So for us, that means that we're seeing 1 in 15 reactions are a TACO, or 1 in 1,500 transfusions. So just to summarize, when we're looking at these things, when we're trying to determine, is this a TACO? Is it a different kind of respiratory distress reaction, or is it maybe not related to transfusion at all? We're taking into account patient risk factors. We're looking at the identification criteria. Is there a crossover between different product types? For example, the RBC reaction I discussed where there was a venifer infusion at the same time. We're looking at how much volume was infused, not necessarily to rule things out, but it does help to understand better what actually happened. And we're also looking at what type of product was used. So we'll do the post presentation knowledge questions now. So the first question again was, which transfused volume is most likely to cause a TACO reaction? 300 mils, equivalent to 1 unit of RBC, more than 300 mils, more than 1 unit, 50 mils or less than a third, or can any volume cause a TACO reaction? Okay, so it looks like most people voted for D. Any volume can cause a taco reaction, and that is actually the answer, the most correct answer. As I said, if it was related to volume, we would see tacos in more often in patients that had had multiple transfusions, as in 2 units, or even if they were in a massive hemorrhage situation where they had multiple units at the same time. Okay. Question 2, what type of blood product can cause taco? RBC only blood components like RBC plasma or platelets, only plasma derivatives like IVIG, albumin, or fibrinogen concentrate, or any blood product can cause a taco. Great. So it looks like pretty much overwhelmingly everyone voted D. All products can indeed cause a taco reaction, as we demonstrated with those 2 cases. Last question, what causes a taco reaction? Is it patient-specific factors like underlying disease, the volume of transfusion, product-specific factors, or a combination of all? Okay, great. So again, it looks like most participants voted D, a combination of all of these factors. A few still voted patient-specific factors. As I said at the beginning, we don't really have a great understanding of what actually causes taco, and I think really the best answer is a combination of all of these. So that is the end of my presentation, and I am happy to take questions now.
Okay, thank you, Sarah. I'm just trying to get the questions in order here. The first question, at what rate should that albumin have been infused?
So our local policy indicates that albumin, 100 mils, 25% albumin can be infused 30 to 45 minutes. Keeping in mind that you do still have to do your test dose, which is the 50 mils an hour for the first 15 minutes for adults. But generally speaking, albumin should go over about an hour.
Okay, is the albumin case reported as transfusion reaction or drug adverse event?
Good question. So we do report it as a transfusion reaction because albumin is a human plasma-derived product. The best way to think of it is anything that actually comes from your transfusion medicine lab or your blood bank is a blood product.
Okay, how slow can you give albumin 100 mils of 25%?
Kind of the same question again. You would usually give it over over an hour. The thing with albumin, or the thing that you really need to keep in mind when you're considering patient as high risk for taco, is the Lasix is probably something that needs to be ordered if it's not ordered. As in, if your physician places an order for something that you might be concerned about, you can either run it more slowly, or you can also make sure that the patient is being given sort of pre-transfusion diuretic to make space for that blood product to go into. However, we do often use 25% albumin in patients that have like renal dysfunction, as in hemodialysis patients that might not be responsive to Lasix. So there's not data supporting like the best evidence at this time. It's just something that we should keep in mind as we're perhaps monitoring our patients more closely, so that when a reaction does begin to occur, we can catch it quickly, as in the case that I presented to you, where they were kind of almost done, but they definitely like acted appropriately and caught it before things got out of control.
We have some physicians that like to give albumin 5% at 100 cc's an hour continuous infusion. Do you restart each bottle at the 50 ml per hour or at the continuous rate?
I've not heard of the practice before, but perhaps you're speaking to us from Burn Center. We don't have Burn Center at our corporation. So generally speaking, so let's use an IVIG as kind of a related example. If you have a dose ordered, all of the vials that make up the dose are considered to be sort of one one treatment, and you don't need to keep restarting the test dose for each vial. So if you're doing IVIG, say 75 grams, and it came to you as 6 different vials, you would do your test dose for the first vial, and then for every subsequent vial, you could follow the monograph to increase the rate appropriately and as tolerated by patient and dosing, but you wouldn't need to sort of restart from your slow rate with every one of them. Now, you'd have to look at your local policy on that, because as I said, we don't give 5% continuously.
Okay. Should the Venofer also be reported as adverse drug reaction due to the death?
Yes, we did indeed co-report that.
Kindly state the 6 identified factors to screen if TACO diagnosis is correct.
You're going to be provided with the slides at the end of the presentation, so I will just allow you to refer to the slides.
Absolutely, thank you. What about Lasix when patient is having a periocentesis?
Yeah, it's a good question. I think I kind of touched on that one already, that if you have a patient that has renal dysfunction, perhaps even to the extent that they're anuric, they're not really going to be responsive to Lasix, particularly if it's something that has been tried in the past. So it's not always indicated, and definitely the MRP should know best if we can even use Lasix appropriately. If you can't use Lasix as a pre-transfusion diuretic, then you definitely just need to be monitoring more carefully and choosing an appropriate rate.
New lot numbers of PPP vials don't require a reduced rate.
I'm sorry, I don't understand that question.
Not sure I understand that question either. So that question is from Emily. So if you wanted to in the chat clarify that, Emily, for us, that would be great. Lasix pre-transfusion more effective than post, usually ordered post or between units at our facility currently.
Yes, definitely. This isn't a new finding, but it is a newer finding that pre-transfusion diuresis is actually more supportive of patient outcomes. If you think of it as in the pre-transfusion diuretic will allow space to be made within the patient's blood. If you give it after the transfusion, you've already kind of pushed that patient into a transfusion reaction, and then you're trying to treat it. The problem with that is TACO is the leading cause of death related to transfusion. So if you were to push the wrong patient into a TACO, you could cause their death. Whereas if we had pre-treated, we might not sort of push them over that precipice. So it's always better to pre-diurese rather than post. Between, I would argue, like that is technically a pre-diuresis for your second unit, but definitely, as Dr. Pendergrass pointed out, we shouldn't be ordering multiple units at once like that. We should be ordering one unit, pre-transfusion diuresis with a post-CBC check, and then start the process again if necessary. And as I kind of alluded to, we should also be looking at things like Venofer infusions to support iron supply and things like that.
Okay. Is flash pulmonary edema the same as TALD?
I assume TALD was a typo for TACO. Flash pulmonary edema. Flash pulmonary edema is basically the same thing, but flash pulmonary edema is not related to a transfusion. It's when we give them fluid in general that just pushes them into an overload. So yes, kind of.
So this is a clarification from the last question. So I think Emily meant, would you not restart the PPP infusion at the slow rate if you had a change in lot numbers mid-transfusion?
Right. Okay. So every single vial of purified plasma proteins or derivatives that we administer to a patient have different specific lot numbers, kind of like how every unit of RBC will have its own specific unit number. Same idea. But we do treat them as one dose and administer them together. So if you were ordered 200 mils of albumin 25%, we don't have 200 ml vials. We would send 2 100 ml vials, and you would do your test dose and then continue the transfusion at the same rate when the first vial was done when you start the second one.
How long should pre-Lasix 20 milligrams be given prior to transfusion?
So you can double check definitely the onset of action for IV Lasix, but I always do it about 15 minutes beforehand.
If giving 2, then do you require additional Lasix between doses?
Sorry, like 2 units? Is that?
I think 2 units in between the two.
I think that if you're pre-diuresing, then you don't necessarily need to do another dose of Lasix. Because if your patient's sort of, at risk of hypotension, you can't continue giving them Lasix until their blood pressure is entirely gone. That's probably a question for a physician.
Is monoferric infusion used at your facility, and are there preferences or risks associated with using monoferric over Venofer?
We definitely have monoferric available now. We give it to our outpatients occasionally, but I understand there's a higher cost associated with monofer there's a higher cost with monoferric at this time over top of Venofer. The benefit is that you can give monoferric faster than Venofer, which is nice for outpatient departments, but I don't know if it's like an out-of-pocket cost. I mostly deal with the inpatients in our hospital, so I don't have as much exposure to that. But really, it's just for now, for us, it's a sort of historical practice that we give Venofer more often still.
Are the rates of TACO among pediatrics comparable to in adults?
That's a great question. I wish I could speak to it, but unfortunately, I meant to mention this at the beginning. My corporation only does about 15 pediatric or neonatal transfusions for an entire year, as in all of my sites combined together. So we just don't really have the data to kind of support or refute the presentation of TACO. So I would love to answer that question. Unfortunately, I can't.
Okay. If the albumin is Q8 hours, do we treat each vial as a new treatment or as one treatment? And do we slow test dose for 15 m each time?
Yes, definitely. If your dosing is 8 hours apart, you definitely are treating it as a new transfusion every time, and you are giving it the test dose of 50 mils an hour, 50, for the first 15 minutes every time, yes.